I'm really proud to introduce Dr. Ruth McNair, AM, Honorary Associate Professor, Department of General Practice at the University of Melbourne, and Adam Borne, who is Professor of Public Health at Trobe University, to talk about the disparities of health outcomes for our communities. Please make them welcome.
Thank you so much, Teddy, for that illustrious introduction. It's a great pleasure to be joining you all here today. And I'd also like to begin by paying my respects to the Gadigal people and my respects to their elders past, present and emerging. Ruth and I are doing something of a double act in this talk, and we'll be whisking our way through a whole range of health disparities experienced by our communities at lightning speed. So strap yourselves in. There is a very large and a very compelling body of evidence that tells us our communities experience health inequalities in a range of different ways. We see significantly higher rates of mental ill health, in anxiety and depression, in suicidality among LGBTIQ community members compared to heterosexual, cisgender or endosex individuals. We see much higher rates of substance use, a whole range of substances, particularly things like methamphetamine among gay and bisexual men. We see higher rates of alcohol use among lesbian, bisexual and queer identifying women. And more than that, we also see instances of problematic use. Sometimes people are using drugs safely, they're doing them in ways that help facilitate pleasure and community connection, but there are also many people who are having a hard time where it's having an impact on their everyday lives and where support is required. We've known for a long time the health disparities in relation to sexual health, and HIV being the most obvious indicator of that, disproportionately impacting gay and bisexual men as well as trans people. We also see very high rates of sexual violence, considerably higher among our communities, and particularly trans and gender diverse people bearing a particular burden in relation to sexual violence. There's a range of cancer risk factors which are concerning among members of our community, again, particularly lesbian, bisexual and queer identifying women, and also trans people of all genders. And we see considerably higher rates of intimate partner violence among LGBTIQ communities. And we also see a lack of support or even overt acts of violence or abuse perpetrated by families of origin. These are just a snapshot of some of the issues in terms of health that we've been facing for a long time. And these issues are true everywhere in the world where we've ever collected these kinds of data. I've been very fortunate in my career to work not only in Australia, but in Europe, in the Caribbean, in sub-Saharan Africa, and in Southeast Asia. And I could be standing on the stage in any one of those countries, drawing upon the data from the local contexts, and it would be painting a very, very similar picture. Now, what that tells us, really, is that there's a commonality in the structural forces that are shaping our experiences. There's something about the structural, the political, the cultural environment which is leading to the same kinds of health consequences here in Sydney as it is in many other parts of the world, and this is something Ruth's going to be touching on in more detail. But as we consider those headline findings about the key issues, we must never lose sight of the fact that these experiences can look very different depending upon the different identities and experiences that we share. A queer person with disability has to grapple not only with homophobia and transphobia, but also with ableism. A person of color also grappling with racism, and of course First Nations people battling and wading through centuries of colonization. And while there's many concerns for our community that are common, there are some that are, of course, are unique and specific, and I think key examples there being access to affirming healthcare for trans and gender diverse people, and in relation to bodily autonomy and affirming healthcare for people with an intersex variation. I want to emphasize one particular point about mental health and suicidality, and this is a pretty confronting slide. It presents data from a large LGBTIQ health survey that we ran here in Australia in 2019, so pre-pandemic, and that's the data shown in the pink bar. The data in the blue column are the best available comparison we can make here in Australia to the general population. And what you're seeing on the left-hand side are rates of suicide attempts in the last 12 months that are 13 times higher than what we observe in the general population. And on the right-hand side, you see 30.3%. That's nearly 1 in 3 LGBTIQ people had attempted suicide at some point in their lives. Maybe you didn't hear me, maybe you were glancing down at your phone, so I'll say it again. That's 1 in 3 LGBTIQ people who'd attempted suicide at some point in their lives. That statistic is really appalling. This is the same data broken down by gender. And what this shows is that the experience of attempting suicide is incredibly high all across our communities. Everyone is impacted. But it is especially high among trans and gender diverse people. That 54% of trans men and 48% of trans women have attempted suicide at some point in their lives is absolutely staggering. And while, as I said, while these data are from Australia, I can tell you that same pattern around how different parts of our community are impacted is true all across the world. And in that context of health inequality, it's really important that we have the healthcare services in place to meet what is quite a considerable need. Yet we still see widespread experiences of stigma and discrimination in healthcare settings, of aggressions, of acts of exclusion. We see staff who are insufficiently trained or are insufficiently attentive to the health needs of LGBTIQ people. Even when we have good quality affirming healthcare services, they often don't exist at anywhere near the scale they need to in order to meet the demand that exists out there. And there is often insufficient political support in countries all around the world, and that compounds the investment that's really needed in the health reform that is clearly evident, that is clearly needed and is evident in the slides I was just talking to. It is great, it is fantastic to have Minister Jed Kearney here today talking about the efforts that our government is making to address some of this. And my final point before I hand over to Ruth is just to say, in that context where there aren't the professional healthcare services available to meet the needs that we have, so very often all around the world we're turning to one another, we're turning to our peers for support, particularly in relation to mental health. And that's something that's amazing, it's something we can celebrate, it's the resilience of our community, but it's not sustainable, and it places an unfair burden on people who themselves are often impacted by mental ill health. So at this point I'm going to hand over to Ruth, who will take us through the second half.
Thanks very much. Thanks, Adam. It is wonderful to share the stage with such wonderful colleagues. Teddy, Adam, Clara, who's coming next. I've worked with these people for many years and will work for many years to come. I want to talk a bit about, firstly, what are the challenges? So what's going on here? Why is our health and wellbeing so different? And no matter what context we're talking about. You know, it can be hard to unpack. I've put trauma at the centre of this. First, what is this image? Some of you who were in Australia during the marriage equality debates will remember this poster amongst many other posters. This appeared around the place in Melbourne and many other cities, and it was put up by opposition forces around equal rights, not just marriage, but equal rights to be a citizen in Australia. And it was conflating the issues, as we see repeatedly. We saw it during the federal election campaign here and in many other countries, conflating issues around same-sex equality, marriage, people with trans and intersex identities, and also people with kids. And this was particularly saying that those fags, those LGBTQIA+ people should not have kids because they're going to abuse them. You know, this was incredibly difficult to experience as a lesbian parent, as a person who's supporting people early in their parenting journey, where I can see the joy and the expectation of people who are trying to achieve a family against all odds. And we had to put up with that along with many other stories. So this is alive and well, the trauma that we experience on a day-to-day basis as LGBTQIA+ people. And it's not just about stigma and discrimination. It's also about exclusion. Some of the young people I'm supporting who have been homeless as a result of coming out to their families as lesbian or bi, trans or non-binary, they've been rejected by those families for who they are, and they often have to leave home. Now, homelessness rates in Australia are incredibly high. So, I wanted to sort of help us to understand that this is not about not just the very overt forms of violence and discrimination that we suffer, but also these microaggressions that happen on a day-to-day basis in our families that should be a safe space, in our schools that should be a safe space, in our workplaces that should be a safe space. And discrimination varies across the subgroups as well. As we could see with the suicidality rates that Adam presented, this is not equal within our community. You can see here from the Victorian Population Health Survey, one of the few population-based studies we have available to us, and I know that will change now, thank you, Jed, for the incredible research funding that will come our way. Adam and I nearly collapsed backstage when it was announced. We can see that subgroups, particularly trans and gender diverse people, have way higher rates of discrimination than, let's say, the lesbian, gay people amongst us. And this needs to change. And just a caveat here, there was not enough people with intersex variations in this study and many other studies, including Private Lives 3 that Adam presented before, for us to meaningfully compare people with intersex variations, and that's a gap, one of the many gaps that we need to fill. So, 2 steps forwards, and maybe many steps backwards sometimes, that we heard this morning in the plenary. I can see, and this is an example of young people of LGBTQIA+ identities feeling stronger and feeling more able to come out as their true identity in particularly schools and family environments. And that's great. We see a much higher diversity of expressions. My son goes to an inner north Melbourne secondary college. I think at least half of his friends and colleagues are somewhere on the LGBTQIA+ spectrum. He's surprisingly straight and heterosexual, sadly, but, we'll work with that. Good lesbian parents, we can raise a straight boy. Anyway, it's great. They're coming out in numbers, they're coming out proudly. However, that is leading to more violence directed towards them, which is just so incredibly sad that it still happens. So much higher rates of harassment and assault in schools and in the society that we live in. I won't dwell on this any more than that. And there's what we talk about in health as a sort of cascade of need, and we see this incredibly focused issue around, is our need being met in the healthcare system? No. So you can see in the Right of Themselves in 4 data that's presented here, 6,390 people in that study, young people who are LGBTQIA+. 2/3 of them had had suicidal ideation at some point. Only slightly over 1/3 had accessed any professional support service. What is that about? Why didn't those other 2/3 of the people experiencing such extreme distress access support services? And if they did access those services, only a bit over half felt that it was helpful. So this is a huge issue in our country. So I've got some wish lists. I want to change the world. I want to educate families. I mean, one of the things that I see a lot in these young, not so young sometimes, aspiring parents is this wish to create a new family for themselves and for their society, but their real concern about how that family will be perceived by their own families of origin, by society around them. So if I could only get those young families, just as they were having their kids, in the maternity ward, and say, have you thought about if your kid is LGBTQIA+? Have you thought about the information that you will need to support them? Have you thought about that? But no, we don't do that yet. And there's so many other things we could do. The wish list, it'll stay there for a while, but I think we do have low-hanging fruit. What we can do is build a much more inclusive healthcare service. What I see in the healthcare service at the moment, and when I'm doing training amongst healthcare providers, is not stigma and discrimination. Yeah, there's little pockets of it, but it's a bit of apathy. It's a bit of sitting back on our laurels and saying, yeah, we're doing a great job. We service everyone in every way, no matter who they are. That is not good enough for our community. We need to have healthcare providers who understand our specific needs, our specific wants, our specific desires around an inclusive health service that is LGBTQIA+ inclusive and knowledgeable. I mean, I'm a GP. I know that we hate not knowing anything about something. Personal failing. And what we do, if we don't know something about a particular thing that a patient's telling us, is we close off. We sort of go blank, or we change the subject. And a lot of my patients tell me that that's happened to them in the healthcare system. What we actually need to do is tune in, is learn, is understand, is say, I'm sorry, I don't know enough about this, I'm going to go and learn about this. I'm sorry, I need to step up. So we are seeing this stepping up in certain areas, a little bit in primary care. There's some primary healthcare networks in Australia that are doing a great job around this, and some that aren't so good. In mental health care, there are some pockets of improvement around LGBTIQ inclusion. In family violence services, particularly in Victoria, we've seen some great money come in from state government to support that. Alcohol and drug services, housing and homelessness, there's a little movement for change. So there's some little hope out there. The image here is just a document that I helped produce for GP Supervisors Association, just to try and get the supervisors and the registrars thinking about this. So my final message is, first, the nothing about us without us. This healthcare provider education has to happen with community, it has to happen with peer-led support, and it has to happen with the diversity of our community. It's not good enough just to talk about lesbian and gay health, which is still an issue. Yeah, I know a bit about lesbian health, but do I know anything about my people with intersex variations? We see a few little engagements around, say, prostate cancer, around cervical screening. Now, LBQT, people with a cervix, are included in the national screening guidelines for cervical screening. Yay, at last. It's taken a lot of advocacy to get there. And we see, for example, this Poster of Beautiful Women, a Breast Screen Victoria initiative to encourage all people with breasts to come forward and have mammogram screening when they reach a certain age. So I'm going to leave it there and say we have a long way to go, but there are glimmers of hope, and I know that this room has capacity to support that. Thanks.